I guess I'm being recorded right now. So, you know, I'll be kind of honest with everybody. When I was a resident, I was terrible at orthopedics. I didn't know anything about it. I had no idea what I was doing. It was only until after I kind of got out and I did some other things that I kind of got a little bit better. But for the most part, we kind of have a real big problem with some kind of basic fractures over here. And what I wanted to do was just kind of go through basically go through two fracture models and kind of pick the commonest ones that are usually out there. So ankle fractures, distal radius fractures, this is kind of going to be your bread and butter. So this is something that we should kind of get used to. Now obviously over here the treatment is usually, every time I end up kind of asking a resident about what they want to do, the treatment usually consists with some form of consult orthopedics or follow-up, we know what the radiologist reads in terms of your fracture. You know, you're going to get to, not all of you, but some of you are actually going to go to a place where there is no orthopedics. So that's going to be you. So you can either learn some of it right now, or you can learn basically trial by fire when you're outside and you don't have the nice friendly constraints of residency. So today, let's see if this works. It's not working. There you go. So basically, wanted to go through a couple things. And like I said, we're going to go through ankle fractures, we're going to go through distal radius fractures. Okay, I don't have a lot of time, so we're probably going to be a little quick with this. But basically, I want to identify, and I want to go through some of the classic ankle fracture patterns so you can identify them based on your fibular components. I want to kind of introduce you to the terminology of the bimalleolar equivalent. Obviously, I spelled that wrong. I want you to kind of understand, and going into distal radius fractures, I want to just kind of go through the classic eponyms because these are going to be something that's going to be on your boards. It's going to be something that you end up frequently getting exposed to over and over and over again. And then I want to basically kind of point out some of the classic distal radius parameters for what constitutes an adequate reduction. And then finally, just kind of go through some of the complications of distal radius fractures. There's some bad things that can happen out there, and I want to kind of at least show you kind of the things that can happen in the long term and then also in the short term. Let's see if this works. Beautiful, ankle fracture. Okay, so everybody's got a foot. Hopefully you've got two. This basically is the medial aspect of your foot. Now I want to point out one thing, okay? I don't want to go into a lot of anatomy or anything like this, but this is your medial mallet, right? This is your navicular bone right here. Just take my word for it. Okay, you see this big strong thing right here, this big wide strong thing? This is your deltoid ligament, okay? This is what gives your ankle stability. This is what gives stability to your ankle mortise. So whenever you kind of look for these medial clear spaces and all these parameters, this is really what you're trying to identify. So I'm sure every one of you got on tennis shoes or something like that. If you want to go down, feel the medial aspect of your foot, go right and feel on the bony prominence, and then just go distal to it, okay? If you feel like a little bit of area that's giving, that's your ligament. That's your deltoid ligament. You have two parts to it. You have a superficial and a deep part. When the deep part gets ruptured, that's when you need surgery, okay? To make it really simple, that's when you need surgery, that's when you need to send these patients out. The complexity is to determine when you need to do this based on what you're looking for on the x-ray. Okay, lateral side, basically pretty much the same, pretty much not as important. Obviously you've got your lateral malleolus right here, you've got a bunch of different kind of ligaments coming across. Just point out basically in terms of things that you should be palpating. Proximal fifth, lateral malleolus, and then obviously you can kind of tell that you end up having a couple different ligaments. I do want to point out to you just a couple different things. Posterior tibiofibular ligament and anterior tibiofibular ligament. You don't have to know these, you don't have to care about these, but what you should understand about these is that this is the distal component of your syndesmosis between your tibia and your fibula. Okay, it becomes important when you kind of start looking at rotational ankle fractures and basically trying to understand the mechanisms behind these. And so this will become a little bit of a component. But just understand that that's a part of the syndesmosis and it's something you should be feeling for. This is just in here for completion, but just essentially I wanted to point out that you end up having a bunch of avulsion fractures that you can obtain. Remember your pseudogenes happens with your peroneus brevis tendons. You can also end up having a little bit of confusion with your posterior tibialis tendon, which kind of attaches to your navicular bone. All those things are on your Ottawa ankle rules, and those things kind of sometimes confuse and obscure the picture. But it's, you were just learning about tendinitis and tendinitides, I guess you could say. Basically, remember tendinitis is when you actively flex or when you passively extend, you should recreate those kind of symptoms. So that's another way to try to distinguish between a tendinitis, or a tendinopathy, I should say more accurately, and an actual fracture. So, okay, so yes, that's broke, right? So the treatment, consult ortho, right? That's kind of like what we do. You guys, you don't have to yell it out. If you want to yell it out, feel free. But how would you describe that? Just think to yourselves how you described it. If you've got loud mouths like me, yell it out if you want to. But right here, right, you've got your lateral malleolus, you've got your tibia. What kind of view is it? It's an AP view. What's the fragment look like? It's what? It's a transverse fragment. Okay, it's a transverse fragment of the lateral malleolus, and that's going to come into play kind of like when we kind of try to understand some of these, some of the mechanisms, and that's going to help you in terms of guiding your management. This fracture right here is basically going to be short leg cast, a walking boot, weight bearing is tolerated. Okay, that's what the treatment is right here, provided there's no tenderness over here, which we're going to get into. Okay, sorry. What's this fracture? What's the view?
It's an AP.
Okay, AP view.
And so you have a convoluted fracture of the fibula.
So what does the fibula look like?
Crap.
How does the fracture line look?
It's a spiral.
It looks spiral. You can refer to that as oblique. Okay? Notice the difference between that other fracture that you had. That's what we're going to go through. And now what else do you have? You have this, right? So this is, you've been taught as a bimal fracture. I want to kind of give you a little bit more detail than that. Bimal unimal is probably a pretty safe bet in terms of kind of understanding what needs to go to surgery, what doesn't. There's a few different caveats there. If you remember basically most of that stuff, you'll be fine. But I want to kind of teach you a little bit about kind of the distinguishing aspects of some of these fractures. But I want you to begin to focus on the lateral now. Okay, that's going to be your key when you start to take a look at these kind of fractures. All right, we're going to go through some of the radiographic parameters also. Okay, so like I said, ankle radiographs, right? You're going to have three. You're going to have an AP, mortise, and a lateral view. You're going to be looking for different things on each view. Okay, so you just saw two APs of the ankle. Everybody knows to look at the fibula, the tibia, medial mal, lateral mal. What I want you to kind of start to be introduced to is to focus on the talus, right? The talus is going to be where you end up having a lot of pathology, and I also just want you to gradually start to look and see for any kind of fractures of the talus. Whenever you start to obtain some x-rays on this, I know you're going to look at this. I know you're going to look at this. Okay, I want you to start to look specifically at the talus, specifically the lateral process of the talus. Sometimes you can have, that's a classic fracture pattern that gets typically missed. Some of your AP measurements that you guys are going to end up seeing is tip fib clear space, tip fib overlap, superior clear space. I know that you've been shown like all these. I could never remember the numbers. It was 4, 5, 10. There was something in between. Maybe a 6 was thrown in there every once in a while. The whole purpose of this, right, is to distinguish whether or not there is a rupture of the syndesmosis. That's the reason why you go through all these numbers. That's the reason why they're important to you. That's what you end up trying to do. This right here is the tip fib clear space, right here. This is the tip fib overlap. Superior clear space is something that I just wanted to kind of make sure that you're just focusing on to make sure that there's some kind of congruency, to make sure that there's some kind of an equidistance between the articulation between the talus and the tibial bone. Okay, the numbers that you have over here, the tip fib clear space, which you just saw right there, 5. Tip fib overlap, some people say 10, some people say 6 or 5, okay? But again, the idea is that you're looking for ruptures of the syndesmosis, and that's why you look for these numbers. That's really what you're trying to look for. I want you to understand the purpose of doing this, then rather than just randomly trying to remember just 5, 10. If you understand the purpose, it'll make a little bit more sense to you. Okay, the mortise you guys know, right? That's something that you're going to always be looking at. Essentially what you're going to do is you're going to have the ankle rotated at 15 degrees so you can get this view. And again, you're trying to look for basically an equidistance between the talus and the tibial bone. That's kind of what you're trying to do right here. The big number right here that everybody's kind of learned about, and everybody's heard about before, is the medial clear space. It should be about equal to or less than 4 millimeters. All right. There also is something called the lateral clear space. It's not going to be as relevant to you, but this is the main thing that you should be looking for. But really what I want you to understand is that this area right here should be equidistant to about this and should be equidistant to about this. Okay. What this is doing, what the mortise is doing, remember we just kind of went over that deltoid ligament thing that's on the medial aspect? That's assessing for this right here. So if this opens up, if this widens, that can indicate a rupture of that deltoid ligament, and we just said that the deltoid ligament is the thing that gives you stability. It's not the fibula, it's not the distal, it's not the lateral malleolus, it's the deltoid ligament. So if that's ruptured, if that's increased, that's going to be a surgical indication. Lateral ankle, May help you a little bit finding posterior malleolar parts and posterior malleolar segments. Bless you. Bless you again. Essentially what you're going to be looking for, like I said, posterior mal. Look at the talus. You can begin to understand. You can try to see the congruency, or excuse me, you can try to see the articular surface between the talar head and the distal tibia. You can also look at the calcaneus, some other things. But like I said, we're looking at fractures today, and we're looking at basically ankle fractures. I know some of you guys get all excited about Bowler's angle, just in case you want it. It's the calcaneal tuberosity, the superior articular facet, and then it's also the anterior process of the calcaneus. It should be between 20 and 40 degrees. That's on calcaneal fractures for another time. Okay, I don't think any talk would probably be adequate unless we kind of threw in the Ottawa ankle rules. Remember, I just kind of pointed out a couple bony prominences, right? I pointed out basically the proximal fifth. Remember, I just said that the peroneus brevis attaches to that. I talked about the fact that the posterior tibialis tendon also attaches to the naviculum. Obviously, we're talking about the lateral mal and the medial mal. All of these things are what's in your Ottawa ankle rules, right? These are the sole purpose and the reasons for why you're looking for bony tendons along those areas, because those are the most high-risk kind of areas where you're going to see fractures. Those are your bony those are going to be your bony prominences that get fractures. I'm not going to go through the original paper. The most recent systematic reviews that I saw one in academic EM, giving you a negative likelihood ratio of about 0.1, and then I ended up seeing another one basically with another one for adults. This was for peds. Another one for adults, basically where you end up having a negative likelihood ratio of 0.07. So it's pretty good, right? That's where you're looking for these fracture segments. There's also a component of can't bear weights. Okay, so obviously, if your patient can't walk, you should probably be getting an ankle foot. Okay, so this is what I really want to kind of get you guys into understanding, okay? And so when I was trying to tell you and to get you to look at the lateral segment and the lateral, the lateral mal, this is why I want you to kind of begin to understand this. You see this fragment. This is kind of the fracture that we initially saw the first radiograph that I showed you. It's a transverse fragment. This was the second one, right? You see the difference? It's an oblique fragment. This one right over here, if this was at the fibular head, what would that fracture be called? A mesoneuf, right? This is basically Weber A, Weber B, Weber C. And I just want you to kind of get into the idea that this is actually what you're this is actually what you're looking for. If you can understand these, you can communicate these with your orthopedic consultant, it's going to help create a little bit more understanding between you two. It's going to help them get an idea of what you're consulting about, if you need to get paid this patient follow-up, and on whether or not they need to come in or not. So, like I just said, this Weber classification A, B, and C depends on the lateral mal. Like, that's really the section that you're trying to be looking at. This was based a long time ago, based when people thought that the fibula ended up when most people ended up trying to say that the fibula was giving stability to the ankle. It doesn't. All right, but the fracture fragment is based on whether it's transverse, whether it's oblique, or whether it's proximal. I want you to look at it in terms of locations relative to the ankle joint. Weber A's are classically distal to the ankle joint. Weber B's are classically at the level. Weber C's are classically proximal to it. Okay, there's another system, the Lauge-Hansen System. Basically, it tries to give you an actual mechanism, and it tries to give you a position of where the fracture is going. It also, the first letter usually denominates what position the foot's in. The second letters usually indicate which position the foot's going. So an SER, which is the most common, is going to be a supination external rotation. You don't need to know this, but your orthopedic consultant may write things like SER2, SER4. And so that's the reason why I'm putting this in, so you can understand a little bit about that. So Weber B's are the most common. And just in case you guys want any kind of review of some of this stuff, I have a lot of stuff in the orthopedic literature, but if you go to Radiology Assistant, I believe .nl, there is a fantastic breakdown of all of this. And so they can give you a lot of this information. But anyway, Weber B's are going to be your most common. Remember we looked at that oblique fracture fragment? That is what they end up having. You end up having that oblique fracture fragment in the distal fibula. You've got 4 stages, but this is going to be what you see. This is going to be your bread and butter. This is going to be the thing that kind of comes into you most often. And so what you end up having, you have a supination and external rotation entry. Now, what does that look like? That classically looks like every other ankle sprain that you've ever seen in your life, right? Basically, the patient is plantar flexed, and they end up having a little bit of an eversion entry. All right, and so there's 4 stages to it. Remember I talked to you about that AITFL thing? That area that's at the very distal syndesmosis, that's the first stage. The second stage is when you get that oblique fracture. At that point, your fracture's stable, okay, if you just have those 2. The next thing that you're looking for is basically an injury to the posterior malleolus or a rupture of the ligament, the PITFL, which was on the back side, and that's that syndesmosis on the back. And then finally, the last component of this fracture is the medial malleolar part, okay? So this would be referred to as an SER2, all right? Notice there's just this fracture right here. It varies whenever you talk about it to a different orthopedic surgeon. Some orthopedic surgeons I've talked to say they don't really care what the fibular fracture looks like. They don't care if it's displaced, they don't care if it is displaced or not. All they care about is the deltoid ligament. Some of the literature actually says about 3 millimeters of step off. Really what you're looking for is if you see this fracture, you should not be looking and you should not be trying to press over here. Obviously I want you to eventually, but your first area of palpation should be right here. You should be trying to assess the deltoid ligament. That's what should be in your note. That's where you should be examining to see whether or not you've got a more severe fracture. Okay, these do fine. Put them in a boot. They'll be great. All right, this is the mechanism that you're going to end up having. Again, basically an injury to this distal area of your syndesmosis, the AITFL, the anterior inferior tibiofibular ligament, and then you see that oblique fracture. All right, that oblique fragment. I think I probably beat that into the ground enough times right now. But they do fine, right? And the idea for why they do fine is because of the fact that you don't have any kind of movement of the tibia onto the talus. Because if you get as little as 1 millimeter, then you're going to end up having an increase in your joint spaces, an increase of your pressure of about 50%. That's going to give your patients arthritis. That's going to end up causing them to have ankle joint replacements years later. Okay, the SER4 is what you need to be concerned about, and this is what you need to be looking for. So I know that you're going to be able to recognize if you've got a posterior fragment. I know that you're going to be able to recognize whether or not you've got this, right? That's the easy part. Anybody can see that. You can recognize 2 big black lines on an ankle. I understand that you can do that. If you see this, obviously this is a bimal fracture. You've now disrupted this deltoid ligament, right? So you don't have any attachment to the tibial, to the distal tibia, to the medial malleolus. And so now this is going to need surgery. But what if you don't have that? There's something referred to as a bimalleolar equivalent, and this is what you should be thinking of whenever you see these fractures, okay? Because remember, you're looking for the actual fracture. The x-rays aren't going to show you any kind of information about this deltoid ligament, and I've kind of harped on this now probably about at least 3 or 4 times. You're looking for tenderness over this. You have 2 parts. You have the superficial and your deep part. The whole point of that Mortise view was to look for any kind of disruption in that deltoid ligament to see if there is basically a shift of the talus onto the distal tibia. All right? There's a lot of debate in terms of how to detect this. Some people try to use palpation, but it doesn't usually work that well. So then there's been a lot of other different ways in the literature which have been described in terms of trying to make that distinction. You in the ER, you're not going to have an MRI, okay? It's just not going to happen. CT scan is not going to help you. So what are you going to do to try to make that determination? Well, one of the things that you can do is a gravity stress view, okay? So basically, you can order this. Your x-ray techs know how to do this, okay? They've had it done multiple times, and they do it multiple times. But essentially what you're doing is you're letting the foot rest. You're letting it hang off the table. You're letting gravity externally rotate it. And so now, if your deltoid ligament isn't intact, it's going to fall down. Okay? The idea is that if you end up kind of having a little bit of disruption and now you end up having some shift of that talus, that you actually have an unstable fracture regardless of whether or not you've got 2 cracks in 2 different bones. Okay? And so that's going to be another patient that you should not be sending out weight bearing as tolerated. You should be saying, no, you cannot bear weight at all. You need to basically follow up because you need surgery. You're going to need a syndesmosis screw to make sure that you don't have any of that shift of the talus onto the tibia. Now, orthopedics just kind of goes a little bit over the edge a little bit with this because there's really no good way to kind of do this. Much in kind of like how we do sepsis care, much in how we do a lot of different things. There's no real one way, right? So there's no cutoff. I can't give you a number. It doesn't exist, okay? You have various degrees. When you go low enough, you increase the sensitivity. When you go high enough, you increase the specificity. If you don't have any deltoid ligament disruption on this gravity view, if it's less than 4 millimeters, you're fine. If you have greater than 5.5 millimeters, and I'm referring to the medial clear space now on the Mortise view, then you have problems, and this could potentially indicate a deltoid rupture. This is that patient, just like Dr. Hassel said, that you need urgent orthopedic follow-up. It doesn't need to be done tomorrow, but it needs to be put in, and they need to be weight bearing as tolerated. And that's one of the things that should be on your discharge instruction, if nothing else. Okay, this is what you're going to look for, and this is what you're going to see on the X-ray. This is how it'll look. Actually, it'll probably look 90 degrees counterclockwise. But nevertheless, this is what you're going to be looking for, and you're still looking for that medial clear space. It's just now you have gravity pointing down, and this is the stress view, and this is one of the ways in which you can try to determine if you have what's referred to as a bimalleolar equivalent. And just because it's not a bimal fracture on the X-ray doesn't mean that it's not an unstable fracture. It still may need surgery. It still may be an unstable fracture. Okay, that's probably the most important one that I can kind of get across to you guys right now. You have a couple other rotational patterns. One's called the Weber A, all right? This, again, is basically the mechanism that you have. You have a supinated foot, and you end up having an adduction, all right? What ends up happening is that when you end up having your foot kind of force in this direction right over here, you end up having, this is essentially almost an avulsion of your lateral malleolus. That's why the fracture fragment is transverse. Okay, that's why you end up seeing that fracture pattern rather than that oblique fracture pattern that you saw on the Weber B. You get that oblique fracture pattern because you essentially have the talus ramming your lateral malleolus up, and that's why you get that specific pattern. This is more of an avulsion fracture. That's why you get that transverse line. Okay, that's the difference. These are almost always stable, but again, you're looking for basically, obviously, any kind of a medial malleolar kind of fracture, and you're also feeling the deltoid ligament as well too. Okay, obviously, like I said, one part is going to be an avulsion, so then you're going to end up having the talus push up, so you're probably going to see some kind of a vertical shear or an oblique fracture over the medial malleolus. Okay, and it's going to look something like this. Obviously, you know this fracture. This is your bimal fracture that you kind of heard of all the time before. Yes, this needs surgery too. It still requires the same treatments. It still requires a syndesmosis screw. It's just a different kind of mechanism. But that's the reason why you have a transverse fracture here on the lateral malleolus rather than an oblique fracture on the lateral malleolus. I will also, again, the stage 1 where you don't have this fracture, where it's just on the lateral malleolus, short leg walker cast. You guys, if you go out to the community, you may have places where they can put your patients immediately in walker boots. That's fine. I've seen in the literature where some people keep describing a high-top shoe. I tried to chase the literature back far enough to try to find this. I never really found exactly where it actually references this. Some people may say this to you. I don't necessarily believe that it's true. But nevertheless, short leg walker cast, walker boot. But the point is, if it's just a stage 1, if it's just the lateral mount, you can use weight bearing as tolerated. Now the Weber C is the one that you guys all know from all your board questions and everything like that. That's what you guys said is your Maisonneuve fracture. And so that's the one that ends up having the proximal lateral malleolar fragment, okay? So essentially you have 4 stages just like the other one, and also I want you to understand you have a pronation external rotation mechanism. It's probably not going to be something relevant to you when you end up describing the fracture, but some people refer to it as a pronation external rotation or PER. The stages kind of go progressively 1 through 4. It actually starts on the medial side. You end up having the exact opposite that you did on that other fracture. Now remember when you had those Weber A's, you had a transverse fracture, and this time right here, you're actually going to have a pull of the lateral, of the talus to the lateral aspect, and you're going to end up having a transverse fracture now over on the medial aspect, okay? Obviously, you guys understand, and you guys have been told long enough that basically you end up having a mechanism that goes up the syndesmosis and it creates a proximal fibular fracture. All of these deserve surgery, okay? All of these are basically going to be fractures that need to be treated. You're going to put these in an AO splint. You're either going to have orthopedic come down, AO splint, and these are going to require urgent fixation. It doesn't need to be done tomorrow. Different facilities actually have different cultures. You know the culture over here is basically send out everything. Yeah, we'll figure it out a little bit later. And that's okay as long as you give the proper precautions. But again, this is a person with a bimal fracture, and so this is unstable. This needs surgery, but you need to make sure that you give the proper instructions to your patient. This is strict no weight bearing. Okay? The treatments of all of these are basically going to end up starting with a posterior mold, okay? Now, when you put on your posterior molds, you should be considering a couple different things. Do any of you guys know exactly kind of like what span these posterior splints should be? Do you go up to the popliteal fossa? Do you go up to the ankle? Kind of about something? You should go about 3 millimeters, you should go about 3 to 4 finger widths from the popliteal fossa, right? You should try to make an effort to avoid the fibular head, all right? Because what ends up happening if you put your mold and it kind of compresses the fibular head?
You get a palsy.
What?
You get a palsy.
A palsy of what?
The common perineal.
Right, the common perineal nerve, right? And so you can end up having a foot drop. Okay, so it's something that you need to watch out for. So you need to be careful about how much you're splinting these. Obviously, even if you're not splinting, even if you're splinting, bless you again, you can end up having injuries that you can cause that can be iatrogenic. So it's something that you need to watch out for. Now, you can also end up going to the metatarsal heads. If any of you want to come up here, I can splint you real fast, but if not, we can kind of move on. Is everybody somewhat comfortable? Yeah, I see a lot of thumbs up and a lot of nods and a lot of shaking. Now remember, if you have an unstable fracture, what you can do is you can add an AO splint. And so essentially what you're doing is you're taking the posterior mold and then you're also adding what's referred to as a stirrup splints, okay? And so that's basically a splint around the foot that kind of goes onto either side. You're trying to give it basically compression and you're trying to give it stability on 3 sides. Now let me ask you this. You have a fracture. It's a little bit, we'll call it basically a SER4, okay? So it's a Weber B, it's got that oblique fracture fragment on the lateral fibula, and then it's also got a little bit of a medial-malleolar transverse fracture. So it's a Weber B, an SER4, it's unstable, it's bimalleolar. You're gonna basically end up splinting this fracture. There's a little bit of shift. You are in your little shop on your own, you're basically in Kansas or something somewhere. There's no orthopedic surgery. You're gonna place your posterior splint, you're going to place your stirrup splint. Which direction are you going to put on the splint itself in terms of your force? Now I know you want to keep your splint dorsiflexed, right? You don't want to keep it in equinus because you don't want to develop any Achilles tendon flexor contractions. What way are you going to press on the ankle? What way is your talus going to shift? What are you concerned about with the rupture, right? You're concerned about the deltoid ligament? Okay. The deltoid ligament is where? It's on the medial side. Okay. So if you have that fracture, what I want you to do is after you've placed your stirrup splint, I want you to press medial to lateral. Okay. I want you to press on that to kind of try to keep and maintain that talus within the tibial plafond. That's what you should be doing if you try to address these fractures on your own, because you're trying to maintain that ankle mortise. And that's one of the things that you'll do. When you see your orthopedic surgery resident place these splints, and you see them kind of put a whole bunch of force, that's what they're trying to do, because they're trying to maintain that mortise. All right? Any questions? Okay, that was really quick. That was basically on ankles. Does anybody have any questions on ankle fractures and rotational? No? Okay.
You want a model to put on the posterior splint, you can use me. Does anybody want to see how to do it? Everybody knows how to do it.
So I was just told Dr. Gergensheimer, I do have the stuff, but if we do it, then I don't have time to do distal radius. We can do it afterwards if we need to, but thank you very much for volunteering. Okay, so guys, distal radius is another one of those common fractures, and the other one, the reason why I ended up choosing this fracture is because this is what you see, right? We have ice everywhere. Little old lady fell, fooshed, and she ended up cracking her wrist. Okay, it's very common. This is what you see all the time. Usually you're going to see 2 different kind of mechanisms. It's either going to be young kids that are going to be in some kind of a high-speed mechanism, or it's going to be a low-impact person. It's going to be a low-impact mechanism, usually on an elderly person. Classically, it's going to be a female, all right? Just because of bone density and osteoporosis, and that actually comes into play later on. Okay? So, actually I want to kind of go back. So everybody kind of understands in terms of physical examination of your wrist, everybody kind of understands that you're going to be basically assessing the nerves, right? So you're going to be assessing radial, ulnar, and medial nerve. So one of the biggest things that you need to be doing whenever you assess these fractures is you need to be assessing the median nerve, okay? Now, do you guys know what function gives the median nerve, or what function in the hand constitutes an intact medial nerve? I see somebody crossing their fingers. That's not right. Okay, yeah, so it's going to be, exactly, so it's going to be opposition of the thumb onto the pinky, okay? So that's essentially what you're going to be looking for, right? Obviously, you can also, the area that has unopposed sensory innervation of the median nerve is going to be the distal aspect of the volar index finger. The reason why you care about this, and the reason why you should always be documenting an intact median nerve, is because of the fact that you're going to end up classically having 2 kinds of injuries to your median nerve whenever you have a distal radius fracture. Now, classically, most of these are going to be Colles fractures. One is going to be a median nerve contusion, right? You're going to have a little bit of an injury to your median nerve, and you may get a little bit of paresthesias. The next thing is acute carpal tunnel syndrome. All right, and so this is one of the things that you definitely need to be kind of looking out for. So this is going to be a rapid progression and rapid paresthesias of the median nerve that basically comes about very quickly. This is the equivalent of basically having a cord compression. All right, and these are one of the things that you need to be looking out for on some of these patients. You need to document median nerve function whenever you do that, and that the fact that it's intact. If you start to see this developing, this is one of those this is one of these emergent things. This isn't kind of like send it out and kind of have it follow up later. This is one where you need to call back your orthopedic surgeon and they need to reduce this immediately. Otherwise, you're going to lose the function of that nerve. If you have any open fractures, I think I was talking to one of the residents yesterday. We were talking about the DiGustillo classification. Just remember that you're going to need certain antibiotics. It's not done randomly. It's actually done by the DiGustillo-Anderson classification. There's multiple ones. You can look it up online. It's not something that you need to remember. Okay? So when you look at the radiographs, when you end up having these fractures, what I want you to basically look for is, you're looking for radius, you're looking for ulna. Now I saw Dr. Hassel's kind of review, we were kind of looking through basically the carpal bones and everything like this. The two or three carpal bones that I really want you to focus on in some of these, I want you to look at the scaphoid, I want you to look at the lunate, and I want you to look at the triquetrum. Okay, these are the things that you should be looking for. All right? So when you're looking at X-rays of the wrist, essentially what you're doing is I want you to focus on those initial bones, like I said on the I want you to focus on those initial bones right here, but I want you to notice something, right? Do you see the distal radius right here? Which way is volar and which way is dorsal? Which way is over here? Volar, right? This way is dorsal. I know. I just wanted to make sure. Look at the actual tilt of the radius. Where does it look like it's going? Does it look like it's going that way? Does it look like it's going that way? Or does it look like it's perfectly upright? It's tilted slightly volar, right? There's about an 11-degree tilt of basically the distal radius. And this is important to maintain function. If you go and try to grab a pencil or anything like that, notice what position you put your hand in. You're going to flex it a little bit, okay? You don't want to lose that, and this is going to be one of the parameters that you need to follow if you try to reduce these fractures on your own. Okay, what I also want you to point out is that there's a nice little line that you see over here, and you guys have learned about this a little bit with carpal instability. But you see this right here, this little Pac-Man looking bone right here? What bone is that? Lunate, yeah, that's the lunate bone right here. And you see this bone right here that kind of comes into? Capitate, perfect, right? So you see a nice little formation of the radius, the lunate, and the capitate. And you should be looking for this, and you should be trying to maintain this when you try to do your reductions yourself. Obviously, I don't think it goes without mentioning these are the bones and everything like that. You guys can identify this on a lateral. This is what you're looking for on a dorsal, or excuse me, on an AP view. Again, radius, lunate, and capitate. You should be looking for those. Initially on that AP, you're also going to be looking at the scaphoid and the triquetrum, excuse me. Okay, your radiographic anatomy, I want you guys to try to reduce these fractures. Okay, if you work with, I know the culture is basically to have somebody else come down and do it for you, but you guys should be doing this, and if you understand what you're looking for, I'm perfectly okay with you doing as much as you want to, but there are certain parameters that you need to be looking for. Now, we just ended up talking about basically the direction of the distal radius, right? You said that there was a little bit of a volar tilt to it, and that's about 11 degrees, and that's essentially what you're looking for.